officially like to welcome you all to our Geriatric Resource Ohio Work Group, GROW, ECHO for May 25th, 2022. The work for this ECHO is supported by our Geriatric Workforce Enhancement Program, our GWEP. We have lots of acronyms, in a cooperative agreement through HRSA. Our GWEP is housed at Northeast Ohio Medical University in Rootstown, Ohio. My name is Margie Sanders. I am the project director of the GWEP grant at Neomed, and I will be your facilitator for this ECHO. The title of today's ECHO is Advanced Care Planning and the Conversation Project. Before we begin, I would like to introduce the faculty for today's ECHO. Denise?
Hello, I'm Denise Kropp. I'm the ECHO coordinator as well as the data manager for the GWEP grant.
Thank you. Dr. Jen Drost.
Good afternoon. I'm Dr. Jen Drost. I'm a geriatrician from Summa Health in Akron, Ohio.
Brandy Krasinowski.
Hi, Brandy Krasinowski. I work for Direction Home, Akron Canton Area Agency on Aging and Disabilities, and I am the Director of Project Management, Quality Improvement, and Provider Relations, and I'm also the social worker on the GWEP grant.
Thank you. Sue Fosnight. Is Sue on? I don't see her. Okay, if Sue's not able to be here, she is our clinical lead pharmacist. She is our pharmacist on the grant, and she's the clinical lead pharmacist at Summa Health. And Sue Hazlett.
Hi, Sue Hazlett. I'm a nurse from Summa Health System project manager for the GWEP grant.
Thanks, everyone. So today's Grow Echo didactic is being provided by Kris Baughman and Ruth Ludwick. Kris Baughman, PhD, is an associate professor of family and community medicine at Neomed. She received her PhD in sociology from Indiana University at Bloomington. She conducts health services research with a focus on advanced care planning, conversations about treatment options, and patient values between healthcare providers, patients, and their families. She also does research on health disparities, examining issues of access to care and bias. Ruth Ludwick, PhD, RN, BC, CNS, is a nurse, researcher, and educator, experienced in academic and clinical roles and experienced in guiding nurses and students from undergraduate through PhD in research and evidence-based projects. She continues her own research with emphasis on topics related to gerontology. She has a successful history of cross-discipline grant writing and management. Ruth actively disseminates her work and has numerous national and international presentations and publications. She retired in 2010 from Kent State University as a full professor and is currently a professor emeritus. She works independently as a consultant, speaking, writing, mentoring nurses, nursing students and faculty locally, nationally, and internationally. And I am so honored. These are both wonderful friends. Our case presenter today is Dr. Jen Drost. So for just a few minutes for some housekeeping items before we start. Please mute yourself during the presentation. To communicate with the group, use the chat function and share all chats with the entire group. If you are on the phone, use *6 to mute or unmute. Please make sure your name shows on the screen as well as your face so that our ECHO team will become more familiar with each other. We really do strive to build community. And during the case presentation, you can unmute to participate in discussion as you wish. So just so you're aware, today's session is being recorded. Also be aware that the details of the case have been changed to ensure patient privacy. And we have quite a large group, so we are not going to be able to take the time to introduce everyone, but please make sure your face is showing and that your name is on so we do know who is here with us. And at this point, I'm going to turn things over to Kris and Ruth. Thank you.
Okay, thanks, Margie. And can everyone see my slides okay? They showing up?
Yes.
Okay, great. So today we're going to be talking about advanced care planning, and we'll get more into the definition a little bit later. But we want to describe the need for advanced care planning, sort of compare and contrast the difference between advanced care planning, advanced directives, and also medical orders, and then give you some resources at the very end that you can use. And so when people are surveyed about their end of life wishes, or they usually about 70% say they would prefer to die at home. But only a little more than 25% have those written documents that state that. And of those that haven't done those written documents, the excuse that most people give is that I just haven't gotten around to it. And I'm guilty of that myself. Even trying to, I've done my advanced directives, but they need to be updated, and I haven't gotten around to it. As people get older, they tend to focus on advanced directives more often. So if you look at the group that's 65 or over, about 51% have those ACP documents, versus only about 25% overall of all age groups. Advanced care planning rates are lower among Black and Latino people relative to white people, and they're also lower among those with less education and less income. So there's some health disparities there. So think about whether you've had these conversations and with whom you've had conversations about advanced care planning. Now, advanced care planning is broader than just the advanced directives. So advanced directives are the legal documents, but if you go broader to advanced care planning, this is a definition that we like to use. This was from Dr. Sidor, who took a group of clinicians and also researchers and did a Delphi panel to come up with a definition that everyone could agree on. And she says, advanced care planning is a process that supports adults at any age or stage of health. And Ruth is going to talk about this later on in the presentation, about those milestones when advanced care planning should take place. And it's in understanding and sharing your personal values, life goals, and preferences regarding future medical care. The goal of advanced care planning is to help ensure that people receive that care that's consistent with their values, goals, and preferences during serious and chronic illness. So in terms of advanced directives, in 1990, the Federal Patient Self-Determination Act was passed, and it required that all healthcare facilities participating in Medicare had to provide information about healthcare decision-making rights to patients, ask patients if they had advanced directives, educate their staff and community about advanced directives, and not discriminate based on that status. So think about your own agency. Do you ask these questions? Is it more of a checkbox? They have it, they don't have it, or do you actually have those conversations with patients? And how do you respond as a patient when asked these questions? So in terms of legal documents, we have the living will, which are directions for future medical care. And these often contain specific do nots. So do not resuscitate, do not hospitalize, do not tube feed, do not ventilate, are just some examples. And then you can also add things in that you would like to see at the end of life. Durable power of attorney for healthcare, that's when you're naming someone to make those decisions for you when you're unable to do so. In terms of the Ohio law, there's the DNR comfort care arrest, where providers treat patient as any other patient without a DNR until the point of cardiac or respiratory arrest. And at that point, all interventions will cease and the DNR comfort care protocol will be implemented. And then DNR comfort care, it lists what providers will and will not do. So examples of things that you can still do, if it's necessary for comfort, you can administer oxygen, and you can also obtain IV access for hydration or pain medication to relieve discomfort, but not to prolong death, just for comfort. And you may also contact other healthcare providers, such as hospice. Examples of do not, you no longer can perform CPR or administer resuscitation medications. Now, the post is even more specific than the advanced directives. So you have that broad category of advanced care planning, and then you have the legal documents, and then the post are physician orders. So physician orders for life-sustaining treatment. And this is a form filled out by healthcare professionals, and it makes specific what you do and do not want towards the end of life. And it travels with patients across settings. So once you fill out that form, it should go with you from the hospital to the nursing home to home care. And it has the force of any other type of medical order. Some states have specific laws that support the post forms. Ohio doesn't, or I don't think they do yet. But it is used by some facilities in Ohio. Ruth, you want to take it over from here? Oh, you're on mute.
So we're not going to talk about now how talking helps. In fact, it's more than talking helps. Talking is essential. And those of you who are providers, physicians, social workers, and those of you who've been doing research in this area know that this is ground zero for what needs to happen for advanced care planning. And not only you doing the talking, but a lot of listening, a lot of inquiring, a lot of getting at what do people want. And as we change our focus from end of life care solely to what do we want to do for different stages of our life and where we are with quality of goals, you'll start to see, if you haven't already, why this talking is essential. I think a couple of caveats are important to note. One is that a lot of times patients are waiting for us as providers to bring it up, and providers have a tendency to wait. Well, we'll take my clues from the patient or the resident, depending on your setting. And really, it's a mutual admiration society. Both need to participate, both need to introduce it. And as oftentimes the person who's in more of control of conversations, if you're a professional, it really may fall to you. And jump-starting these conversations, we found over and over again. And I'd like maybe shake of heads or a chat, yay or nay, if you haven't found that to be true. That a lot of times people are waiting for somebody to bring it up. They're glad to have at least somebody open the door and start those conversations. Have you indeed found that? I've certainly have. Yeah, Margie's saying yeah. And I think, Margie, you know, as you work with students, and those of you who may be students, I can remember this is always an issue. They go, but what if I say the wrong thing? What if I? And if you're just listening, you're not saying the wrong thing. So two major programs that I'm asked if you've had, I'm not going to go into details, but we have proprietary and non-proprietary ways to approach this. Two examples of each are Respect and Choices, which obviously is been around for a long time, got good traction in Wisconsin. It is proprietary. Conversation Project is non-proprietary. And we will certainly provide the slide deck. I see that as a question, so I'm trying to watch the chat as well. So the Conversation Project is non-proprietary, but there's a million of these. There's even apps now that you can use that are put out by organizations for how to do advanced care planning. And that might involve a nice discussion in as we move on to talk about some of those experiences. Have any of you used these particular, you can do a shake ahead, or have you used one or the other? Margie, you've used Conversations Project, I think, right?
Yep. And Respecting Choices.
Okay. Okay. My guess is there's been a mix. Anybody used anything different? Okay. Kris, you want to keep us going? I don't want to get too far off track. So Kris and I have been doing this work since 2009, and that dates back to with our good buddies on here, Margie, as well as Sue Foss Knight and Sue Hazlett and yada, yada. I mean, like, you know, we did this way back when, part of that first initial peace grant. Jen, you might have been part of that with Kyle Allen too. But our area of work that we've done is with area agencies on aging. So we're glad to see Direction Home here because they really gave us our first foot in the door on some of this work. We did a project with family medicine physicians looking at self-efficacy of physicians related to advanced care planning. And Kris can maybe talk about that later if you're interested. We've had a lot of uptake from across the world, really, on people who want that self-efficacy scale. And then lastly, we've getting the patient perspective with work that we've used from the health and retirement study from at the University of Michigan, where it's housed. Because research isn't enough. Oh no, I'm just going to say one quick thing. You need to look at what your role as an individual or working within a community, a committee, organizational, professional association could be for policy advocacy. So there's more than one-to-one practice work. We're going to focus on that. But if you go to the next slide, Kris, what I did was, because I was interested in practice guidelines and policies, I worked with the American Academy of Nursing, where I'm part of a group of folks who were interested in this topic. And we wanted to present to the American Board of Internal Medicine our practice guideline, and called Don't Wait, Don't Delay Advanced Care Planning. And we had it written. It looked like it was going to go through, but the way that they're bundled within our organization, ABIM did not want just individuals, and no other clinical guidelines were coming forward for our group. So it kind of got shelved. And they said, rather than waiting around, why don't you do an article? So we did an article, just recently came out, and it's ACP at Life's Milestones. You'll see the authors up there. I happened to, I think I was looking at milestones today just to see if I missed anything. And the first hit I got was for our article. So it's in preprint, and here's a link for it as well as I think you're going to, now I know you'll find it on PubMed. But what we did was, based on what the work of the National Academy of Medicine did with death and dying and dying in America, we put together a little graphic to talk about what are some of the places that you can do advanced care planning at life's milestones. And if you think about it, this really grows out of the definition of SUDOR. SUDOR's work in 2017, I think, really moved advanced care planning along. We started to put some nomenclature on things and recognizing that we were really limited in the terminology we'd been using. In a like manner, then, they talked about milestones. And so we started to say, let's get more publicity out on milestones. And in fact, the Canadian government has a clinical guideline on don't delay. And if they've got if you're not familiar with the Canadian cross-national framework on advanced care planning, it's a wonderful, wonderful resource for you. So we've tried to look at how do you normalize advanced care planning at different stages of adulthood. And some would argue that there's a place for pediatrics. We've stayed away from that. That's a whole field, but there's quite a bit been done on advanced care planning within the pediatric setting with those with serious illnesses. But let me ask you just quickly, can you think of other milestones we ought to be thinking about besides these broad categories that we've noted here?
What about having children?
Yes, absolutely. Absolutely. So you start to think about it. This is not exclusive. It's not exhaustive. And I think as you start to think through these, you'll think of others. I just note, by the way, Jen's comment about POLST and MOLST. And to say that what was interesting, Jen, as a side note, we did an article and Kris and I did, and one of the critiques was, I don't know why you're asking about, why you're talking about this problem of do not hospitalize. Everybody's got it as part of their POLST agenda. And we were like, oh my God, this was from a major review at a major journal. So there are a lot of misconceptions about that. So I'm glad you put those details in there. Appreciate that. Kris? Okay, so what I put together then from that article, because we were kind of instructed that idea was about practice. So we looked at in the article, we talked about practice guidelines for practice and research and professional education, but I'm going to focus here just on practice tips for as clinical guidelines ideas. And within that, talk about timing, patient education, documentation, and equity, diversity, and inclusion. So the first here is, and I won't read these each to you, you can take a look at them, but to make some comments as you read them. The first, Kris was very good saying, you know, she had done hers, but it needs updated. So I think that's the other thing that we need to say when people tell us that is that we've done ours, we've recently updated ours. Yeah, be honest with people. Yeah, no, I need to do mine. And think about some of the barriers you're facing, the same barriers that other people are facing. How do we help them through with those barriers? Think about where you practice. Are there other potential opportunities you can use it to normalize these discussions? I know one of the organizations that I was involved with, Director of Nursing, a couple of years back after I retired, we introduced advanced care planning into the heart failure clinics, which a lot of places are doing. But back then, I mean, this is 7, 8, 9 years ago now. That was still relatively new. And the other issue is, what about turning off the defibrillator? You know, so they're in heart failure clinic. They've had the defibrillator in for years, maybe. Now, what are we going to do? Do they want to continue to have that defibrillator operational? Are there any of you can think of some other kind of things that in your practice? I think of a direction home. There's some great opportunities there.
Well, a lot of times when I'm dealing with my members and we're working on advanced directives, it's like maybe they had them and or didn't have them, and then their health situation has changed. So maybe it was heart failure, but now it's heart failure and chronic pain, or maybe they had their son as their power of attorney for healthcare, and now the son and the person's goals aren't aligning anymore, or there's been some sort of family conflict. And I get so often oh, my kids will know what to do. I'm like, yeah, but you don't want your kids to have to make those decisions for you, because they will live with that, you know, and, you know, you don't want that. So,
right.
Those
are great. Those are really good examples. And I see Sibley put in EMS, absolutely, and also primary care clinic. And I have a story later that I'll share with you about that. So moving along about emergency services. So also then counseling and education, use a person-centered approach. And this is where getting to know the person is just so critical. And some of the things you just talked about, Heather, where there's personal family conflicts and so forth, that doesn't come unless you know the person. People aren't forthcoming about that. And that's a great intro to say to people, are you still having good conversations with these people that, you know, are your family? Are you still contacting them? Those are easy, open questions. How have relationships been with your family now that you've gotten more ill? Those are ways that you can kind of start prying open those doors a little bit for that conversation to start happening. So looking at these for patients and families and involving them right along the way in terms of advanced directives and the broader iterative process. On this third one, I recently had a family member whose husband had the legal documents of the living will and durable power of attorney, and he had that. And my sister-in-law was quickly going downhill. This was right prior to COVID. And her children wanted one thing, but they didn't want to fight with father. The father wanted another, but the father just didn't understand. Well, he had the advanced directives. He really wasn't considering, was this the way this individual would have wanted to be living on a respirator with her lungs totally not salvageable, and waiting for that ventilator to just stop. And I think we're going to talk about a very similar case towards the end, Jen, as you do your presentation. You want to keep going, Kris, because I know I don't want to take too much on any of these ones placed. Documentation is another area that is probably, in some respects, the easiest and hardest. Easiest because we've got tick boxes for yes, we've got it, But then we've got this there. We haven't done a good job on explaining the contextual factors that allow us to let somebody know what's going on with somebody or why they're making those decisions. So they may have made those decisions prior to being ill or once they've gotten ill. So another example of this is that you want to say, yeah, this person told me they don't want this. And the reason they said they didn't want it was they'd already had a cardiac arrest, survived it, and did not want that to happen again. That happened to twice within my family, my husband and my father. So I know, you put that context on it when you're talking to someone, they get it. So that context, if you can share that within the record, although certainly putting something in a record doesn't always mean people will read it. So encourage people to tell their stories for why they believe that. People will have a tendency to remember it if you can put a story with it. One other comment on this slide before, as I let you read them, is that we need to develop an ontology. We need to clarify what our terms are going to be. If you think about it, we often think of the do nots, but we still need to address, what about do not transfuse? What about stopping the defibrillator? There's a whole slew of activities, a whole slew of terms that we need to really figure out. And even do not hospitalize. What does that mean? What are the exceptions? How does that get placed into protocol? I have recently, and I think this is a worthwhile story to tell. My husband has a form of dementia, and he had a cardiac arrest. He's in palliative care, and he has a do not hospitalize order, and of course a do not resuscitate. And he was getting some counseling services, and when we filled out the forms, it had a place for what hospital should they be sent to. And I said, I refused to fill it in. I refused to say what would happen. And they were like, well, what if he has a heart attack? You know that happened when a counselor was actually on the phone with one of our patients. And I said, I don't care. I will be there. And so, Kris, I'm more of the time. And so I say that because that's the kind of thing that really is important in terms of this, getting that information out and documenting it. Okay, you want to go to the last one? So then diversity. And on this slide, there's a lot of comments, but I will put one thing just in perspective, that health literacy is one of the strongest predictors of advanced care planning. So with the different languages, with different cultures, and there's been a lot of good work done. Sudor, in fact, in 2019, did some work with Spanish and English diverse groups in California and used the Prepare program and got some really strong results. I would just be careful that one of the things we've done poorly on is with people who have differing family relationships than we think of as normal. And what those may be, I mean, I think This Is Us is a good example of how those can be very different for all of us, and we should be just cautious to make sure that we try to provide equitable care. Okay, Kris, next slide. This is part of our scale, and I'll leave it for you to look at what physicians told us they were most comfortable in and what they were least comfortable in. And I would ask you to think for yourself, what do you think you are most and least comfortable in? Because I think part of this whole process involves introspection. Kris, you want to move to the next slide? So in conclusion, note that it's embedded in end-of-life care, and it's not routine. It's underutilized and often still a checkbox. One size does not fit all. And there is an interplay among all of these factors in terms of how effectively you might do it on a one-to-one very well, but at a system level, it's done pretty poorly sometimes. COVID certainly has been an opportunity and a curse when it comes to advanced care planning. We did some searching on COVID as we were preparing this last article that I shared with you. And it was interesting. There's been a significant web intake on advanced care planning since COVID came out. And so I think I'll leave you with that the last couple of slides have good resources, but there's a million more that you're certainly welcome to offer to us as well. Okay, and that's me. And Kris, I did that in 18 minutes, no, 15 minutes. So I watched. I'm a little
Yeah,
over, not bad.
I was just sending you a personal message to let you know that we were getting close to the time. Sorry.
Okay, it's okay. Oh,
Thank
this
you.
is good. We got a couple of good comments here from Heather. That's a good one. And Jen, my kid will know. Yeah.
Yeah,
I mean, both of those are good comments. I just saw those.
oh, where did I go? All right. Any other questions or comments for Heather? Is it necessary to get these documents notarized? No. Oh, go ahead.
Well,
Sorry. Answer.
it does carry weight to notarize them, but they don't have to be notarized in the sense that, but the other thing is there are certain things that only can be done by physicians or primary providers, such as nurse practitioners. So like those particular documents cannot only be done by the provider.
I guess my question is, if I work with a lot of members who are, you know, homebound, it's hard for them to get out. And so if they have if they have an idea, is it better to fill the form out? I mean, is it binding if their doctor has a copy of it, or if it's in their file, if it's not notarized?
Go ahead, Margie.
As long as they have two unrelated signatures, it is legal and binding. So they just have to have two, you know, get two neighbors.
But it's difficult when you are living in your home and you're not able to get out of your home to find those two people to sign on the document. So when we talked to care managers a few years ago, they were very concerned that they couldn't get people, and they did not want to be one of the people signing the document because they were afraid that they would you know, somehow influence the person, and they wanted to make sure that they weren't having any influence over those advanced directives. So it raises some kind of ethical issues
in people's minds. Now, I mean, I think it depends on the relationship as well. Jen, you want to say something too, I think?
I was just so just to clarify what those documents that you can have, right? The witnessed signatures to validate them being your power of attorney in those living will forms, particularly the Ohio ones. And yes, I agree kind of how that you know, ethical overlap has been probably blown out of proportion the vast majority of the time. But I know from a physician standpoint, definitely discouraged to being a witness to those documents. The do not resuscitate, the physician or the medical order, again, can be physicians, APPs, meaning NP or PAs can sign those. Probably some additional folks in there as well. You know, those ones need the medical person to sign off of them. The Ohio form does have a line for the patient and or power of attorney to sign it as well. It is not required, but does add validity that that person is in agreement with that order. So.
Thank you.
So I'm sorry, I just, this is so important. I'm just trying to make sure. I always tell the people on my caseload to make sure that they have a copy on file with their primary care physician. Is it something that easily gets scanned into their chart and will follow them wherever?
Heather, you ask the $1 million question. You need to tell people to make numerous copies, keep them with them, keep them at home on the refrigerator, share them with friends and loved ones, talk about it at Thanksgiving. You can't have enough of these, because the problem is we don't have a portable order system here. And I think our case study at the end is going to talk about that a little bit. And even the case I just gave you, my husband, they were like, well, no, you know, I've got to have that. What if he has a heart attack while the counselor's talking to him? I said, well, I'll be there first off, and I know what I'll handle. I know what we discussed. I know what he wants. So absolutely, you can't have enough of these. And that is a real issue. I will tell you, I have a friend who does some digging on this. She's kind of my silent investigator when she goes to different places for her care. Not that she's in poor health or anything. And the answers you get about, well, we've got it on record, and they say, well, where is it? They don't have any idea. So it really behooves each of us to carry our own with us and to help people to say they need to speak up. I'm aware of people who have been intubated when in the waiting room, the family had the do not ventilate order. So that you can't have enough of those copies. Does that help? It doesn't answer it. Because it's not a good answer. It's a horrible answer.
Thank
It
you.
is horrible. And I kind of relayed my, in my one comment there. I mean, the other challenge, particularly around do not resuscitate, do not intubate, do not hospitalize, right? An individual, certainly of sound mind, and or if those decisions have been made by their power of attorney, has the right to change their mind at any point in time. So even if I have a signed do not resuscitate order, that doesn't necessarily mean that that's what I want the next time I'm hospitalized or my medical situation has changed. And so even though they're transferable and transportable, I guess is the right word, transportable, between sites of care, we still need to continually have those conversations, which I think is such a challenge. And we see this, frequently of folks in the hospital, they're in the hospital, they're acutely ill, they've come in with a heart attack or a stroke or, something. And they're like, what, if I get worse while I'm here, I don't want CPR, I don't want to be intubated. But they go through their recovery and they get better or to a baseline that they now find an acceptable quality of life. And now they say, I'd want that. So yeah, just emphasizing that point of ongoing conversations and how challenging it really is.
And the do not hospitalize is another good one. I mean, that's one that Kris and I are working on. So it's like how that's interpreted. And I mean, would you do not hospitalize because, you've got a fracture, or do you do not hospitalize because you're expecting that you're at a very serious point in your life and you just don't want further treatment? And so it's quite there's just a lot of nuance of words that we need to do better definition of and better explanations on.
Well, thank you so much, Ruth, Kris. Appreciate this.